Right, we are in the zone of Gastro Med. We are on the ward. I'm ready to answer some more questions. Let's see. We're starting with a 28-year-old pregnant lady. Presents to ED with confused and agitated state. Itching her arms vigorously on exam. Patient complains of right-sided abdominal pain during palpation. She's got baby in there, right-sided abdo pain. She tries to speak. Doctor notes her breath smells. Has a sweet fecal smell. Okay, sweet fecal smell. Can't say I've smelt that, but which of the following is most likely the diagnosis? I know it's really hard to diagnose acute cholecystitis in these people. She's itching her arms vigorously. Okay, let's get rid of some of these, because we're thinking she has some severe pruritus going on. Don't think I've ever seen an appendix do that. Don't think I've ever heard of ectopic pregnancy. Is this part of the pregnancy though? We don't know how far along this pregnancy is. I don't think an ectopic would do that anyway. Liver failure, yeah, that could do it. Acute cholecystitis, it depends how broad we're going, because I don't think there's going to be, they talk about, oh, does she have a temperature? She has that right upper quadrant, right-sided abdo pain during palpation. It doesn't say if it's upper right or lower, which would make me a bit more worried about ectopics. Diverticulitis, I would be most concerned about this liver failure. I'm pretty sure you can get some weird smells and breaths from liver failure. And there's pain on right-sided. And that's the only thing that obviously explains this icterus that's going on. Let's see. Easy. Okay. Feta hepaticus. Sweet and fecal breath. Sign of liver failure. Alright. Feta hepaticus. Every day is a school day. At least we got a question right. Next question, we have a 52-year-old man known with alcoholic liver disease and cirrhosis undergoes an OGD to screen for esophageal varices. Brilliant. A number of high-risk varices are reported and medical prophylaxis is recommended. What medications would be appropriate? I see a bunch of beta blockers. I know it's not going to be telepressin. That's going to be, if there is a bleed, we're going to be giving telepressin of the varices. So that's not indicated here. I think it is a beta blocker, but they've given us 3. I don't think I've ever heard of amlodipine being given. The only one I feel like I've prescribed in similar sounding situations has been propranolol. Maybe it's about cardiac selectivity. I actually couldn't tell you. From being on the wards, I think I could see propranolol being given. Maybe metoprolol. If it is, it's probably a guideline thing. A non-cardioselective beta blocker is used for prophylaxis of esophageal bleeding. We know that about propranolol. Lovely. Telepressin, as we said, vasopressin analog indicated an acute management of variceal bleeding. Alright, we're happy. At least we saw not to do telepressin. We'll take those wins. Next up, we have a 54-year-old female, presents with a 3-month history of dysphagia, affecting both food and liquids from the start, along with symptoms of heartburn. Most likely underlying diagnosis. Pharyngeal pouch, they've not mentioned any halitosis, so my past mode brain is saying no. Gastric adenocarcinoma sounds pretty severe, given the mildness of the symptoms. Benign stricture, could be. Esophageal cancer, could be. Achalasia, most likely. Getting a little beak appearance, bird beak appearance on barium swallow. I'm going to go achalasia. Alright, easy. Dysphagia affecting both solids and liquids. Bird's beak, there we go. I remember some things about achalasia. Pneumatic dilation is increasingly preferred. First line option. Okay. Over cardiomyotomy. What's the Nissan fundoplication for gourd? I can't really remember. Would you ever do that for this? Anyway, we're not going to dive into the weeds. Next question. A 55-year-old man presents to ED, intense abdo pain, bloating and fever. Right. Denies, okay, no vomiting, urine is okay, bowels are opening, fine, no blood, brilliant. He has liver disease. There it is. He had an acetic tap 4 days ago in a specialist nurse clinic. Okay, so that sounds like there's a bit of smoke going on here. Right, let's have a look. Given the likely diagnosis, what is a gold standard diagnostic investigation? So if he has decompensated liver disease, and we're thinking about likely diagnosis, abdo pain, bloating, fever, we must be worrying about SBP. SBP, I only know one thing. We look at paracentesis. Would you do a liver ultrasound scan? I feel like they're not in this situation. You're looking at the structure of the liver. Any sort of swelling or infections or induration might be able to tell you some bits, but let's not mess around. Paracentesis is all I know about SBP. That's what we do. Easy. Confirmed by a neutrophil count of over 250 cells per month. What do they say about the ultrasound? It's a wrong answer. It would not explain the new symptoms of fever or abdo pain. I suppose it's talking about gold standard investigations here, so next. Right. We have a 35-year-old woman comes in reporting 2-month history, epigastric pain following meals. Sounds familiar? She's otherwise fit, not taking any medications. She's tried Gaviscon, which has not helped her symptoms. Which of the following is the most appropriate management? 2-month history, epigastric pain following her meals. So is this just a little bit of reflux she's had going on? Why would we try a PPI at half dose? I don't think it's sufficient. That's a 2-month history. Do we refer for gastroscopy if it's 2 months? Are you meant to try PPI first? I feel like these are guidelines. I can't remember now. Gastroscopy, so if we're doing imaging, what is the time wait? The difference between these PPI doses, why you do one over the other. Maybe if you tried it for 1 month and it's 3 months of symptoms, then you refer for gastroscopy. That sounds sensible. Full dose. Why were they talking about half doses of PPI? Right, next. Oh, I've got a good streak going on, actually. Okay, let's see if we can get the full 10 out of 10. We have... Oh, Hep B serology. Perfect. Prevents GP fatigue and jaundice. Emigrated from Vietnam 10 years ago. No significant past medical history. No reg meds. He's jaundiced. No hepatomegaly. Fine. So, those are okay. Bilirubin ALT, we're looking at... He does not currently have a hepatitis infection. He has serum antibodies and core antibodies, but just IgG. IgG is the long-term antibody and IgM is the acute phase antibody. So he does not have it and he previously had it. Alright, there we go. Some questions are just like that. Diagnosis of UC is suspected. Which part of the bowel is most likely to be affected? Okay, let's read the actual question. 25-year-old man presents with bloody diarrhea, systemic upset. Blood tests show platelets fine, blood cells fine, CRP a bit up, HB fine. Okay, where in the bowel is UC? We know terminal ileum is classic for Crohn, so we're not going to put that. We know that it's right at the bottom of the colon, down in the rectum for ulcerative colitis, because that's why we like to give the PR stuff, for good stuff. Lucky boys. And girls, but this is a boy. Rectum is the most commonly affected site. I think that's, I don't know, that just makes the most sense to me. Terminal ileum is not a common site for UC involvement, more frequently involved in Crohn's disease. However, in rare cases called backwash ileitis, there might be inflammation around the terminal ileum in patients with extensive ulcerative colitis. So pancolitis. Wow, okay. Due to reflux of colonic contents into the ileum. That's pretty wild. Okay, didn't know that. Good to learn. Oh, a short question. Yeah, sometimes these are the worst. Primary biliary cirrhosis is most characteristically associated with NA antiribose. I'm pretty sure it's A. That's not rheumatoid and not ANCA. Is it one of the ANCA? I feel like that's when you go into the P ANCA and the C ANCA antibodies. I'm pretty sure it's AMA. And yeah, that is from smashing flashcards. and a bit of recognition. What are we talking about? Associated with various types of vasculitis, such as granulomatosis with polyangiitis or microscopic polyangiitis. And next, here we go, hepatitis serology. Most likely cause of this patient's abnormal liver profile. We have a 64-year-old male referred to a liver clinic, persistently deranged LFTs for the last 3 months. 1 week ago, he received a course of Comox. He is an ex-IV drug user, hypertension, type 2 diabetes, and a little bit overweight. He consumes 17 units of alcohol per week. Recent liver ultrasound report showed increased hepatic echogeneity. Right, what are we looking here? Let's go from the top. ALP a bit up, ALT a bit up, AST a bit up, gamma GT fine. That's a weird symbol for gamma GT. Weird. Albumin a bit low. Maybe dietary. Maybe SCTs. Okay, he does not have a hepatitis B infection, but he does have a serum, so he was previously vaccinated because he does not have the core antibodies. Fine. So we don't think it's Hep B, or we don't think it's Hep C. He's not really that fat. You can get non-alcoholic fatty liver disease in more commonly in diabetics. Is it drug-induced liver injury? He doesn't really. These aren't crazy numbers. These are regular numbers. So I think it's going to be drug-induced. I don't think there's enough data to support the others. Okay. Obesity. He's overweight. 32 isn't like a crazy. Am I being mad? Fine. Obese. BMI over 30. Increased hepatic. I should have thought about the actual liver ultrasound. That would have been more sensible rather than just going off vibes. Fine. Non-alcoholic fatty liver disease. Does it say anything about the diabetes? No. Alright. We almost had a clean sweep there as well. Now, what do we have? It's number 10, last question of the bunch. I'm not looking. Oh, wait, I do know these. Okay. Which of the following is a characteristic of ulcerative colitis? Perfect. Lesions anywhere. Okay, that's Crohn's. Granulomas, that's Crohn's. Skip lesions, that's Crohn's. Pseudopolyps. I honestly cannot remember. Inflammation in all layers, that's Crohn's. Alright, we're going to have to do it by removing. I remember smashing the knowledge tutor on past medicine for this stuff, so hopefully, there we go. 9 out of 10. We'll take it where we can. Pseudopolyps, seen on endoscopy. Fine. And that's all we're doing today. Let's jump in, cock.